fairly clearly that our digestive system has not evolved to be open for business 24/7, really. So by us eating without any defined breaks throughout that 24 hours, we're actually harming ourselves. So it turns out that part of the reason we have excess weight is because we have this attitude towards food, which, as long as it's available, we eat it. So in fact, there is very little connection often between hunger and eating in many cases, right? We just eat because food is available, because we have company, because we've been offered food, or because we're bored, because we're stressed, because it is there, right? So that situation has to fundamentally change. We have to say, just as there is time to do certain things in our life, there should be time for us to eat and time for our digestive system to have a break as well. So at its most basic and simple level, that's what intermittent fasting is telling us, right?
So absolutely, and you actually introduced me to this almost 2 years ago.
Mm-hmm.
If you recall that time, you asked me to watch this video, and I'm like, of course, if it comes from you, I can say I won't watch it, or I cannot fake it. So I'm like, I watch it, and then we started actually having more discussions, and we included this in our Bariatric Friday episodes. Now, originally, the idea was this was going to actually prevent aging.
Yes,
and then while they were focusing on the aging, then they find out that actually this actually works out for the weight loss at the same time. Now, the fasting is pretty common in many of the religions as well. And now looking back, we do this as part of our diet, but then, in the old days, I remember I used to fast with the family for an entire month. And the idea was that you wouldn't eat during the daytime. And they still do it. I think they think I may be still doing it anyway, but but I do this, which the idea of cleansing almost, right? So then we are able to kind of just get to a different discipline. Now, it was working for aging is because, I think many people didn't understand that our body is like one big machine. So this is when people don't understand, they think that each organ is just independent and then they are doing whatever they are supposed to be doing. But even if I eat just like one apple or just a small piece of chocolate, the body is doing the entire thing that it would do for a big meal. And the aging kind of makes sense from that standpoint. So, because if you are actually making this entire system work for a small piece of food, versus if you can eliminate those and then just kind of focus on like 4, 5, 6 hour range, and then the rest of the time your body is doing resting. While it's helping aging, it's also helping the weight loss. So now, one of the things that I read, this is also actually helping for those patients with diabetes. You may remember one of the first things that I asked, if people, if they are suffering from diabetes, can they do this? Is it like risky for them because the long time that they are not eating? The idea actually is there's a different program that they can utilize and then get through this whole thing with once they are at full speed, I guess, at some point, because they are going to lose weight, therefore diabetes will be gone. So different utilizations are happening, but how are the patients taking this when you ask them? So they come to you and they want to do surgery and they are kind of focusing on the surgery, and now we ask them to do this diet, this fasting. How do they react to this?
Actually, surprisingly, a lot of patients are very receptive to this because remember, there isn't only one regimen for intermittent fasting. There are a variety of regimens, right? And all of them are based on the fact that we will have an eating window and then we will have a fasting period during that 24-hour time of a day, right? So a day is limited. It's 24 hours. Once that day is over, the cycle starts again. And the question is, do we assign a certain number of hours in our waking hours in which we decide not to have any calorie intake? I think that discipline itself is very, very important, because we do not have that discipline in our daily life. When we look at our culture, when we look on how we live. If I have to take you back, for instance, to before I started doing intermittent fasting myself, as a surgeon, Kemal, I would be fasting completely on 2 occasions, right? One is when I'm asleep, right? When I'm asleep, I'm not eating. And 2 is when I'm performing surgery. When I'm performing surgery, obviously, I have a mask on. I'm in a sterile environment where there is no availability for food, and I'm focused on my surgery, right? As soon as I finish my surgery and I've done my documentation, what I do, Kemal, is I would go to the break room. And what is in the break room? Snacks, coffee, tea, right? And then you just sit there, and it is so habitual to just grab on whatever snacks they have. They used to have this peanut butter and jam snacks, particularly in the hospital, with a cracker that, you would just get there. As soon as you grab your coffee, you would grab that as well, and you would just eat that, right? And then there is lunch. You sit and you eat your lunch. And then you have another procedure. You come back, there is a break, and you do the same. And then maybe you go to the office. Your office, you're sitting down, and in the checking in area, or in the office of the manager, or in the office of the other admin people, there would be different type of snacks, and you don't even think about it, Kemal. You just take one, and then you go and you take one. So what is happening essentially is
I do it every day, because
absolutely.
And Anna, don't listen to me. There's a chocolate tree here in front of, in the hallway. So now, not only I have to fight myself, I have to fight them to remove that, and they don't. They're hearing me right now, so I know that they're probably smiling or laughing, but like, it's difficult to say no to that. Like, it's one of the best chocolates. Like, and you see it, it's like a tree shape, and you can just pick up whatever you want, how many you want. Luckily, we have cameras, so I don't do more than 2. So, but we do it, and then that ruins my diet.
Yes, absolutely. But also remember, culturally also, one of the ways to relate to people is to accept the offers for food from people, right? People offer you something and you accept it. That really strengthens your relationship, right? And as a society, we do that. So that availability of food and that intake of food on a continuous basis does have consequences. And of course, the most obvious consequence, Kemal, is that there is ongoing intake of calories. And once the body has used the calories that it needs for energy expenditure, what is it going to do with the excess calorie? The body is trained to just store that excess calorie. And what does it store it as? As fat. But there is another very important side that, when we look at it from a medical point, is very, very important. And that is, every time we are taking some type of calorie, Kemal, what we do is we increase the insulin level in our blood, right? That's what we do. Insulin reacts immediately by spiking. It's produced by the pancreas and enters our bloodstream. When insulin gets up in our blood level, what is the job of insulin? Well, the job of insulin really is to open up, particularly fat cells, to take on the energy and transform it into fat. And on the other hand, what the insulin does is it prevents the fat cells from releasing fat, right? Because it's saying we have enough energy in the bloodstream. So insulin really is a weight-gaining hormone, right? And every time we are taking something in our mouth, we are getting the insulin to go up, and we are increasing our chances of gaining more weight, right? So very often,
so if you don't mind me asking,
yeah, of course.
I just want to, because we assume that everyone understands everything that we say, and this is the way that insulin actually, the role of insulin in our body is. It's like very simple, straightforward when you are explaining, but then when you are not there, it's not that simple anymore. So when you say it, and then we follow everything that you say, but just so that I just want to break that down. So when the food intake is bringing the insulin level up.
Yeah.
Right. So we
Absolutely.
eat, insulin goes up.
Yep.
So then the two responsibilities of insulin, one is the store, open up the fat cells for storage.
Yep.
Another one is to prevent the fat cells to release
Yes.
energy, right?
Yes.
So that actually is a kind of like a really simple, straightforward, maybe picture of why certain people us dealing with this weight issue, because it's pretty simple. So when you are when you are storing at the same time, you are preventing for things to go out. The storage gets bigger and bigger and bigger, and then your storage space is limited. So what's happening is you are expanding. So that's how we are gaining weight.
That is absolutely it. That is, in simple terms, that's exactly what is happening. And what we are saying with intermittent fasting is we want to interrupt that process so that the insulin level stays low a longer period of time. Actually has been undertaken that has really delved into this, and it has shown that many patients who are actually seeking bariatric surgery because they're struggling with morbid obesity actually have struggled with sexual dysfunction at rates that are much higher from the general population, right? And why is that? Well, there are a number of factors, obviously, right? One is the fact that obesity itself, the addition of excess fat inside the body, is not just related to it, to the person having a higher weight when they are, on the scale. It does actually have impact on the health of the person, on the metabolism of the person, right? So from a hormone point of view, hormones are very important in our sexual health. From a hormone point of view, there are actually changes, there are physiological changes that are related to obesity, okay? In men, for instance, obesity results in lowered testosterone, right? Testosterone is the main male sex hormone. And that's actually what gives us a deep voice. That's the one that increases the bulk of muscles, that is related also to sexual desire and drive, right? And obesity, sadly, is related with decreased testosterone. And in women, there are hormonal changes also that occur with obesity, not as pronounced as it is in men, but clearly there are some, right? There are actually some hormonal conditions like PCOS or polycystic ovary disease that are related to hormonal changes that are much more common when obesity occurs. So on the one hand, you have obesity directly affecting our physiology, our hormonal balance, that is going to lead to sexual dysfunction. And then, of course, there are the other issues. Remember, we talk about obesity having an impact on other aspects of our health, whether it's cardiovascular health, whether it's diabetes, right? So if you have obesity and you have cardiovascular problems like high blood pressure, or if you have diabetes, these conditions themselves also affect health. For instance, men who have type 2 diabetes are more likely to have erectile dysfunction, right? And then, of course, we use medications to treat all these ailments, and those medications themselves also will have a detrimental effect on sexual health. And with all this, I haven't even touched the psychosocial aspects of obesity and their relationship to sexual health, right? So poor self-esteem, the presence of depression, this will have very, very strong negative effect on sexual health. So obesity, coming from many, many aspects, actually does have a very negative impact on sexual health. And that is part of the reason also why obesity is related to a poor quality of life.
So the benefit of having sex versus our patients who are going through the surgery right now, surgery process, or maybe even after the surgery, like it's going to take certain time to lose weight and get better and all those things. But do patients bring this up to you when they have in the consultation or any of the follow-up visits?
Indirectly, Kemal. It doesn't come up directly, right? But indirectly, patients talk about having poor self-image. Or very often, many of our patients will tell me that they haven't had a partner for a very long period of time, right? And that in itself reflects this, right? And also, this has been shown even in studies, Kemal, and I do remember us mentioning it in our previous session that some studies have shown that women with a higher body mass index are more likely to report that they haven't had any sexual partner for the previous 12 months when compared to women of normal weight, right? So we do see that. So patients may not bring it up, openly, but we can get it from other, information. For instance, one of the most common questions we ask our patients to try to figure out whether they have sleep apnea is if they snore, right? Very often they will say, well, I do not know. I don't have a partner right now, right? So lack of sexual intimacy, which is related to, to the dysfunction itself, also is reflected in the relationship the patients will have, right? Or lack of relationship, obviously.
Well, that makes a lot of sense, right? So now we are going to come back to some of these, but what about the puberty? So there are some studies suggesting that this is actually delaying the puberty. Is that the case for the teenagers?
Absolutely, because obviously part of the developmental changes that occur at puberty are closely related to sexual maturity as well, right? So if there is obesity at that stage and there is lack of those, for instance, in young men, as they are maturing, if there is decreased testosterone levels because of obesity, there will be a decreased development of sexual organs, there will be decreased development of their voice, and there will be decreased development in their sex drive as well, right? Not to mention, obviously, other issues which have to do with self-image, young men who have large breasts, right, called gynecomastia, for instance, are less likely to be confident about themselves and seek partnership or be much more active, when it comes to getting partners or thinking about their sex life, right? Similarly, in women, obesity is associated with polycystic ovary disease, which is an imbalance in sex hormones as well, where women have an inability really to either have a regular menstruation or ovulate regularly, right? One of the key hallmarks of polycystic ovary disease is the presence of immature follicles, which are eggs that have failed to mature that populate the area around the ovaries, essentially. So definitely obesity occurring at puberty will interfere with the normal development of the young men and women.
So now, just like any other disease, what I see, I kind of call this like, I think these illnesses are kind of like races, or they are sexes. So this one is one of those. It's kind of like sexes in a way that it has different impact on women and different impact on men. Now, in terms of you mentioned the erectile dysfunction, and any time this BMI over 28, the risk of developing erectile ED, let's go, by 90%, the chance of increasing that, which is, well, for many men, this is a huge problem. And, this is, again, like we see patients, like I see it in the chart, when patients are talking about it, because I see doctors are providers, other healthcare providers that are addressing these issues, but there's always that little, shyness. Well, there shouldn't be any. This is a health issue, which, again, the reason I started with the benefits of sexual activities is because when you are, it's one thing that you don't want to have those benefits, but the other thing is that you cannot have those benefits. So then the decision is not up to the person at that point. And this is why we are kind of treating the morbid obesity perhaps aggressively, so that, or most effectively, that people can actually make that decision And if they don't want to benefit from those and they don't want to have sex, that's fine. But at least they should be able to make that decision on their own, right? So the decision shouldn't be made by them. And there's certain studies suggest that it has an impact on the sperm count, that decreasing the sperm count. And those are all different problems. Now, we discussed in our earlier sessions, I remember, menopause and the impact on menopause. Can we talk about that a little bit?
Well, Kemal, before I talk to menopause, though, I do want to really underline what you just said about the higher the BMI, the more likely that there is sexual dysfunction, particularly in men, right? You mentioned erectile dysfunction, but also you mentioned, sperm counts, right? These are real, right? The higher the waist circumference, the higher the body mass index, the lower the testosterone, the higher the levels of erectile dysfunction. I mean, there is no more clear correlation than sexual dysfunction and obesity, particularly in men. And of course, erectile dysfunction, as you said, is an extremely distressing condition that very often it is suffered in silence by many men. But as you said, it is a medical condition. In fact, more importantly, Kemal, it may be the first indication that there are medical problems going on, like, for instance, high blood sugar and diabetes. And this is more likely to happen in men who are obese. And with obesity rates going up so much in our society, these problems are going to be seen much more commonly. So an awareness on the part of the patients that this is something that is a reflection of a medical condition, and of course, more probing by the medical providers to look into this and help patients is very, very important. Hurdles and obstacles and making it hard for them, right? Well, when we are requiring patients to undergo so many clearances, in other words, so many appointments, so many tests, unless we provide them with intense coordination like we have set it up, it becomes very easy for patients to drop out. In fact, it is not surprising, Kemal, that in most programs, the dropout rate is way, way higher than our program. And that is because patients are discouraged, right? And the discouragement happens because patients may be given a set of instructions and told to get it done and then come back without really somebody checking on with them, either by text messages or by phone on a regular basis to make sure that they are succeeding in getting these appointments done. So care coordination may not be the surgery, but it's a critical part of our program. And I'm extremely proud actually to be part of this team, Kemal.
So if we were to, and I always kind of try to see these as if the patient is watching this, so what we want them to know. One is you are going to be assigned to a care coordinator. So you are going to be dealing with one person. Not only they're in charge of your follow-up surgeon appointments throughout the process, but they're also helping you with your specialist appointments. So these specialist appointments, it can be your EGD with the facility, your cardiology clearance, your home sleep study, bariatrician. And based on the blood work that you do, the patients do, we may need to repeat some of those studies based on the values that we have. And having that one point of contact is extremely important from that point. So then you know that it's always going to be one person that you have to deal with. Now, the beauty is we actually talk every day for 1 hour. Yeah. And your case is being discussed in that. So I run one of there are 2 case conferences, Melza Dimak, our program, our practice administrator, and myself, we have 2 teams, and we rotate those teams every 2 weeks. So then we have some familiarity with the patient, so that when we follow up, we are not missing anything from 1 week to the next. And then we actually, our nurses, they report back to us, and then what's needed, what's not. Facility is there, Dr. Erkan is there. Our nutritionists, they join us once a week. and then they report back to us. So once we know that the patient may need more studies, in some cases, cardiac clearance requires a certain test and maybe another follow-up. So all those appointments are done in the same system. So that actually is a huge benefit if we are able to keep the patient in one network, so that we know when your appointment is. Once they are done, we don't need to actually call anyone to get the results or get the notes. This makes it very effective and efficient. And I know that our drop rate, actually, the other day we were just looking at it. So this is why our drop ratio is very low compared to the other programs or the industry standards. So what else we want to?
So essentially, yeah, absolutely. So the important point also, Kemal, is that patients have real lives, right? They have jobs, they have commitments to their family, they have children. Their time is also very limited, right? And they may not very often be able to do things that we ask them in a timely fashion, even with the support of the care coordinators, right? If we are not able to find that out in a timely fashion, reach out to them and say, hey, you were not able to do your blood work, right? You need to do it at this time, or you were not able to come to your appointment with the heart doctor. We need to reschedule that. If we don't follow up in that manner, then it is very easy for the patients to throw up as well, right? So I know from our system, for instance, you have the ability to communicate in real time with patients, either by a phone call from the case conference itself, or by sending an email, specific email, talking about what the issue is. For instance, if it's the lab work which is missing, the email will target that. If it is the sleep study, the same thing. So by doing this, we're actually supporting the patients in doing this fairly intricate process, understanding that they have a real life as well. And I think this is enormously important for our patients. So the requirements are there, right? Everybody has to go through a number of appointments to be able to prepare for bariatric surgery properly. Of course, there is what we call the medical checkups and medical clearances, and that includes, being seen by a heart doctor, for instance. But it's not just an appointment with the heart doctor. As you know, they may require something called an EKG. They may require something called an echocardiogram. They may require something called a stress test, right? And all that will require coordination. We may need to send them for a sleep study, for instance, if there is a suspicion from the surgeon that the patient may be suffering from sleep apnea. The sleep study by itself requires coordination. Getting the sleep study result, and if the sleep study result is positive, patient may require a CPAP machine. And that CPAP machine needs to be ordered specifically by a pulmonary doctor very often, but the CPAP machine itself may have to come from a different a company. That requires coordination. So the peer coordinators are just so critical in facilitating all that. And in our actually practice, we have been in a way lulled into be comfortable with this, and our surgeons actually have taken this for granted. But in many, many other programs, actually, there is a lot more struggle that goes on because patients are not really able to do that. And there may be other things. You mentioned the endoscopy, for instance. EGD is endoscopy whereby, the patient is asleep with a very light anesthesia, and then we put a camera down the food pipe into the stomach and early intestine to figure out, to make sure there are no problems that need to be addressed before the surgery. It's an important component of our preparation, and that requires coordination as well. And then there may be other things like going to see a hematology, a blood doctor, for instance, if the patients have problems with their blood count, or if they have a history of blood clots. So all that preparation obviously is necessary, but it requires coordination. And that's where we excel with our care coordinators and the case conferences.